following podcast is part of a certified educational activity titled Fibrosis, Flares, and Forward Thinking in Inflammatory Bowel Disease Care, Unlocking the TL1A Axis. Access the entire activity and complete the post-test at peerview.com/WDQ860. Downloadable slides and practice aids are also available.
So welcome to this program called Fibrosis, Flares, and Forward Thinking in Inflammatory Bowel Disease Care, Unlocking the TL1A Axis. So I'm joined here tonight by my colleagues Jordan Axelrod from NYU and Millie Long from UNC Chapel Hill. Great colleagues, great speakers, and I'm sure we're going to learn a lot from them tonight. And the goals for today, during this presentation, we have three things that we hope you're going to accomplish. We hope you're going to learn that a treat-to-target approach in IBD management helps optimize outcomes and achieve sustained disease control. And the second thing that we're going to talk about is the TL1A DR3 axis and how that contributes to both immune and fibrotic mechanisms in both Crohn's disease and ulcerative colitis. This may be a very new mechanism of action for you, but I think it's a good time to start learning about it before you actually have them in your hands. And TL1A targeted therapies have shown very promising results in achieving treat-to-target outcomes in patients with IBD. So I'm going to turn the floor over to my colleague Jordan Axelrod. He's co-director of the Inflammatory Bowel Disease Center at NYU Langone Health, across town from me in New York, and he's an associate professor of medicine at NYU. Jordan, take it away.
Thank you. So I'm going to review, sort of set the stage for what you're going to hear about from Bruce and Millie, and we're going to start with where we stand with IBD care. So as many of us are unfortunately aware of, IBD care is really subject to this therapeutic ceiling of our current therapeutic options. And despite the number of agents that we have available, a significant proportion of patients still don't achieve meaningful disease outcomes. And there are many reasons why this could be the case, and we have to start thinking more broadly about how we can break this therapeutic ceiling. So there's some clinical advances to improve our monitoring, improve target-driven management, care delivery, risk stratify patients, and we're going to talk a little bit about that in a bit. And then, of course, scientific advances, new ways of thinking about trials, of course, new therapeutics and maybe even combinations of therapeutics, how we can molecularly stratify patients, borrow from our colleagues in oncology, how they use treatment that is more biomarker or molecular targets. And of course, just a better understanding of disease and maybe how we could think about even disease prevention. So to summarize the unmet needs, these tend to fall into three major categories. That's diagnostic and monitoring strategies, management paradigms, and also therapy selection and sequencing. So we have a lot of barriers right now in IBD management that really result in a lot of treatment gaps for patients. So right now, we don't really have a lot of tools to help us determine the best drug for an individual patient. Many of our monitoring strategies, like colonoscopy, are invasive. I'd say even some of our imaging studies can be invasive if you've ever sat in an MRI scanner for over an hour. And we really don't have a good hold on predictive biomarkers that we can use to help us stratify patients by risk and then target therapies. There's also evolving data about how we should be managing patients when we first think about initiating an advanced therapy, right? Do you go with the most effective therapy that may have a broader side effect profile first? Do you start slow and then move from there with something that we intuit that may be safer but perhaps less effective? And then, of course, just with our therapy selection, we just have an overall lack of efficacy for many of our drugs, right? With a significant proportion not achieving meaningful outcomes. And then there's also lots of issues of safety concerns with our drugs, although a lot of the data supports our drugs are very, very safe. Still, this is a huge concern to patients. So how we're managing patients right now in the clinic really falls under the left side of this screen, where we have all patients and we give them a drug and then we just see how they do. And in thinking about the future of IBD management, we always consider ways where we can use precision, right? So whether that's not just a strategy of managing patients, but also, again, risk profiling patients to target the right drug for the right patient, and then also target a strategy, right? There may be patients who could tolerate a step-up strategy there may be patients who absolutely require a top-down strategy, starting with what could be the most effective drug for that patient. And so the future is really stratifying individual patients, identifying biomarkers that may help us choose therapies and treat them more effectively. So in this talk, in this session, I'm going to wear two hats as both a patient and a provider. So I think that when thinking of our pipeline like TL1A, it always needs to, for me, to be framed in the background of how IBD impacts individual patients, right? So whenever I give a talk where I'm talking about the patient perspective, it's easy for us to look at graphs, and Bruce and Millie are going to review a lot of graphs. But I think what's important about that is that each graph, each data point is a person, right, is a patient. And so, and those data points for outcomes never really go to 100%. So there's a lot of patients that are still really suffering out there. And even if they're not suffering from disease, what we know about our healthcare system and how things are managed is that patients really suffer a lot, not just physically, but also financially, emotionally, and so forth. So those sort of burdens, which can also extend to caregivers as well, are really important to keep in mind. And so when we think about our therapeutic pipeline and even our existing therapeutics, we have to understand how we're meeting patients where they are, not just where they fall on that graph, but also, are they going back to school? Are they going back to work? Are they living life as planned? And are they living relatively burden-free as we would want them to? All right, so now we're going to discuss our diagnostic strategies. So first, we're going to start with some cases that we're going to touch on throughout the talk tonight. So this is Elise. She has a 15-year history of Crohn's disease, 43-year-old woman. She's currently on infliximab, 10 milligrams per kilogram with a reasonably good trough. Dose was increased just 3 months ago. She's still having bothersome symptoms. So saying symptoms alone, abdominal pain, bloating, intermittent diarrhea, no clear obstructive symptoms noted, although abdominal pain after eating could sometimes be interpreted as such. And overall, we would say that she's probably experiencing a partial response based on her clinical symptoms. And of note, she has prior non-response to adalimumab in the past. Now meet Kevin, 32-year-old man with ulcerative colitis, diagnosed 6 months ago. Of note, prior to his diagnosis, he really was having about 15 months of intermittent symptoms. So this is not necessarily brand new as far as a disease manifestation. Who's now here in the office for follow-up, has been taking mesalamine for 6 months, and despite that, and this is like many of our patients, is still having symptoms, stool frequency more than he'd like, continuing to have rectal bleeding, and is also having some weight loss. So certainly 2 patients who are on treatments and relatively still experiencing symptoms. So what we know when we evaluate our patients is that symptoms alone aren't good enough for us to evaluate exactly what's going on. And so when we see patients and want to understand exactly what's the lay of the land, we always think about disease activity. So disease activity is that snapshot of symptoms, a snapshot of disease inflammation at that one time. But that's not really sufficient enough to guide therapy selection, because patients don't happen in one day. There is a lifetime of disease that needs to be managed. And so what's becoming increasingly important in our field is this understanding of disease severity or disease prognosis. So that's really what's the whole picture of that patient. What's the whole natural course of that individual patient's disease? And right now, most of our variables that give us that risk stratification of disease prognosis are mostly clinical, although again, this is an evolving space. But what's most important from this slide is to understand that IBD is not just that snapshot of disease activity in time, it is the whole patient and what their disease course has looked like and may look like into the future. So how do we evaluate patients for sort of the boots on the ground, especially when patients are presenting with symptoms? So these are 2 clinical tools that we can use to evaluate patients, the CDAI for Crohn's disease on the left and the Mayo score for UC on the right. I think most of us on the stage will tell you that we hate the CDAI score. This is a fully symptom-driven score to an extent and has a lot of heterogeneity, and patients whom may have certain levels of inflammation or complications of Crohn's, could get higher or lower scores depending on those factors. So it's a little heterogeneous, but again, is a clinical tool we have that lets us understand what is that snapshot of disease activity right now. And then of course the Mayo score for UC similarly, but this also includes an endoscopic assessment. So there is some objectivity here in terms of disease, visualizing disease via endoscopy. So beyond clinical scores, how else are we evaluating patients? We're all using biomarkers. So on the left-hand screen here, you see current biomarkers that we're using every day in the clinic, and we know them very well, CRP and ESR. These are widely available. They're not terribly expensive, but they're not so specific for IBD. More specific for IBD is fecal calprotectin, which is also being utilized widely now. It performs a little less well in Crohn's disease, particularly small bowel Crohn's disease or jejunal Crohn's disease, but is pretty good for assessing ulcerative colitis. And this, again, is just another inflammatory biomarker that tells you about disease activity in that one moment. On the right-hand side, these are what the future may hold for us when we're trying to understand not just disease activity in a snapshot, but more about that disease severity, that disease prognosis. So some future blood, stool, and even tissue biomarkers that may help us identify patients who could be higher or lower risk for disease complications into the future. So again, giving us more than just that snapshot in time, but a little bit more about that overall picture that can help us to inform therapy selection. All right, and the reason this is important and why we're talking about disease activity and disease prognosis is that while our goal is to make patients feel better and induce remission, we know that having patients feel better is not good enough. And we're going to hear from Millie in the next section a lot more about treat to target and how we can improve care of patients specifically by treating not just symptoms, but also objective disease markers. And that's important because when we see patients early on in their disease, we have a window of opportunity, and you can see from this graph, early on in disease onset, where if we use very effective therapies, we may be able to mitigate that disease severity. We may be able to mitigate that future complication risk that many patients, particularly with Crohn's, will experience, like stricture, fistula, and requiring surgery, specifically if it goes un or undertreated. And so the absence of timely and effective treatment, those complications accumulate, and of course, patients suffer. And once many of these complications are present, specifically things like fibrotic strictures, we have very few current tools available to us to manage those medically. And so again, there's some real impacts that we can make for patients just by getting their disease activity assessment, understanding their disease severity, and initiating effective therapy accordingly. And I'm going to turn it over to Millie, who's going to discuss translating treat to target into practice.
Thanks, Jordan. You set the stage incredibly well, and I'm so pleased to be here to talk to you all a little bit about how we can optimize the care of our patients and really improve their long-term outcomes. And that's truly by, as Jordan mentioned, ensuring that we're not only improving symptoms, but that we're also really healing the patient's bowel. So STRIDE 2 really taught us this strategy, where when you have a patient who has active inflammation, this is used overall in both inflammatory bowel disease and Crohn's disease, you'll actually use risk factors, not necessarily just that snapshot in time, but actually the risk factors for development of complicated disease to treat them appropriately, potentially with an advanced therapy. And then you assess for clinical response, clinical remission. And actually in my practice, I have really started to utilize more fecal calprotectin. So this has become really standard of care for me, where you very reasonably at an earlier time point can assess for a response. I often will benchmark the calprotectin when we have their scope demonstrating their active inflammation. So I know that a Calpro of 500 for that patient correlates with a Mayo 2 endoscopy and ulcerative colitis. And then I can assess response to the therapy and make adjustments. And then our ultimate long-term goal is endoscopic healing, and potentially as an adjunct, I'll show you some data, but in Crohn's disease, really getting to transmural healing. We think of Crohn's as a transmural process, the entire bowel wall being involved. If we can actually heal that, we can prevent downstream complications, things like stricturing, et cetera. And in ulcerative colitis, while not technically a goal of treat to target. If we are able to reach histologic healing, we do recognize that that's a more durable remission, and that in fact that's actually associated with a reduced risk of colorectal neoplasia over time. So we've actually mitigated their risk and prevented a complication potentially in terms of development of neoplasia. So again, it's a process where we're working with our patients and actively monitoring them to potentially reach each of these goals. But interestingly, when we think about our patients' goals, those may actually be different than what our goals are. My goal is to really heal that bowel fully. Of course, I want my patients feeling better. But this is a study that actually asked patients and providers the same questions. And patients and physicians did align on the most bothersome symptoms, things like urgency, abdominal pain, and fatigue. But patients actually believe that their current therapy will control their disease longer than physicians. We recognize that, that we don't have quite the durability of remission that we wish we had. And patients really are concerned about corticosteroid use, and they really prefer steroid-sparing regimens. When you look specifically here in terms of QOL goals, there are some differences that you can note amongst the dark bars are physicians, and then the lighter bars are patients. Where, from a patient perspective, they very much want to kind of increase the ability to care for their family, to increase their ability to travel, kind of quality of life factors. Whereas physicians, we're really focusing on, the idea that we want to heal their bowel, the idea that we want to potentially increase their ability to work and attend school. We kind of need to understand and take our patients' goals into our decision making and help to ensure that we're meeting those goals. I think many of my patients, when I talk to them about my goal of, I want to get you feeling better, let's hear what your goals are there, but I also really want to heal this bowel, you have to educate as to why, that is important. And in many instances, you want them to define what remission is for them. What is their goal? In some instances, they want to be able to go out with their friends on a boat and not have urgency. And we want to get them to that goal, and meeting them where they are and understanding that, I think, becomes important. So we're going to revisit the patients that Jordan introduced to us. We'll start with Elise, our 43-year-old woman with Crohn's. And remember, this is a pretty typical scenario. We use a lot of anti-TNFs first line. This is actually the second TNF that she's been on, now infliximab, previously on adalimumab. She's got a good trough level, but she's having ongoing symptoms. And frankly, the symptoms, it's not totally clear whether these are inflammatory. And I think it's really important for us as providers to ensure that we are treating inflammatory symptoms, because obviously symptoms not linked to inflammation would not respond to a change in anti-inflammatory therapy. And she's experiencing this potential partial response and prior non-response with adalimumab. So obviously, using a treat-to-target approach, we're going to ask for some more objective findings. And so over on the right, I do check a fecal calprotectin. So her fecal calprotectin is up. This helps me to understand there is ongoing inflammatory activity going on. I need to better define where that is and then optimize a treatment regimen. Her endoscopy shows deep ulcerations and cobblestoning, and her MRE also shows bowel wall thickening in the distal ileum. When you're looking at imaging, it's important to understand whether there is any pre-stenotic dilatation. That is a different kind of stricture where the bowel gets dilated above. That really, to me, is starting to be thinking about, is a surgery needed here? So we don't see that. So this is inflammation, potentially without a significant stricture causing pre-stenotic dil. And just to focus you a little bit on the left-hand side, that's an intestinal ultrasound picture. And I'll hear Jordan and Bruce are also doing this in their centers. But that shows us we can measure bowel wall thickness. That correlates with inflammation. And that Doppler signal, the red and blue, really tells us that there's active inflammation going on. And that can be used point of care, not only to diagnose that this is inflammatory, but also to assess response. So quite clearly, she is active, and we need to address really the next steps. So when we're thinking about that, we want to think about what our goals are. And you saw that ultrasound image with that thick transmural involvement. If we can heal that, we're actually going to have better outcomes. And so this study actually looked at the need for hospitalization and surgery amongst patients that actually reached the goal of mucosal healing, meaning endoscopic healing, as compared to not only mucosal healing, but full thickness transmural healing. And you can see that all of these really objective outcomes were better if we can actually reach the transmural healing. We also look at longer-term outcomes, this deep healing, so the presence of both endoscopic and radiologic healing. Again, that full thickness, has that healed? When you look at major outcome-free survival, and in this particular study, the outcomes were ones patients really cared about. It was hospitalization, surgery, need for corticosteroids or adjustment of underlying advanced therapy. You see that this outcome-free survival is very much almost one associated with deep healing as compared to much less so over time with varying degrees of lesser healing. So, and when we want to assess this transmural healing, there are many ways we can do that. And I would argue whatever you have at your fingertips, if it's cross-sectional imaging, that is great. Intestinal ultrasound actually correlates pretty well for detecting this ileal inflammation as well. You can note when you look at this study that compared both, the various stars and dots are really pretty well correlated. So a cheap intervention like intestinal ultrasound can actually provide us pretty accurate information in terms of estimating the presence of disease, the extent of disease, both in the small bowel and in the colon. I do admit, doing intestinal ultrasound, this is a much better test in the distal terminal ileum. It doesn't work as well as you move up. And so if I truly have someone with proximal small bowel disease, I'm following that person radiologically and not through intestinal ultrasound. So this was the Stardust study, which was a study that actually looked at dose titration of ustekinumab and assessed endoscopic healing through a SES-CD. And this was one of the first studies that actually used intestinal ultrasound, and that showed that patients who really, this intestinal ultrasound was a good marker for achieving transmural remission. And as you can see this early. And so I think that becomes important. It's a very good marker for response. And so we've talked a little bit about monitoring, what our goals are, but I think probably just as important, if not more important, in terms of actually being able to achieve those outcomes is the timing. So we really need to be able to initiate therapy early. It becomes A, much more effective, B, it prevents those downstream complications, and at least in my practice, once someone has that deeply seated, deep ileal ulcers, they are just so hard to heal. And so this study, Profile, asks the question, what if we treat patients early? And what if we treat them early with biologic therapy as compared to a step-up approach where we're monitoring, and if they fail a corticosteroid, they'll get the next therapy. If they fail that therapy, they'll get one added. This study actually also looked at a biomarker that was thought to be predictive. Wouldn't it be great if we had a predictive biomarker that if it was present, you knew that patient needed the more early advanced therapy, whereas if it wasn't present, a patient didn't need that? Well, take-home point, the biomarker did not work at all. And so we don't yet have that predictive biomarker. But if you focus on the left-hand side of each of these figures, what really worked was early treatment. So patients were randomized to one of these two approaches. And most of these patients, the median time between diagnosis and being randomized was 2 weeks. So this was really early. And when you look over on the left at the primary endpoint, which was actually steroid-free and surgery-free remission, nearly 80% of patients at 1 year met that in the individuals who were started on, in this instance, it was a biologic, an anti-TNF plus a thiopurine, as compared to those who kind of had to earn each step of the medication. Also, the secondary endpoint over on the right, and this endpoint was actually endoscopic remission. You'll note a markedly higher rate amongst those who initiated the biologic early. So I think this is telling, and I think it's important, and I hope that this can change our practice where we can have our therapies be much more effective and potentially modify the disease course. In ulcerative colitis, we talked about the idea that if you can get to histological healing, it actually improves outcomes. This is a concept called disease clearance, where you combine the fact that they're clinically feeling better, the endoscopy is healed, and histologically there's no evidence of active disease. And it really predicts longer-term outcomes that are important to patients. Reduced corticosteroid dependence, lower rates of hospitalization and surgery, and really this reduced risk of developing dysplasia. This is something that I really use in my risk-benefit discussion when I'm talking to a patient about initiating an advanced therapy, that if I can control their inflammation, I can actually reduce their risk of colorectal cancer. That's important. And that helps them to understand that there may be some risks associated with these therapies, but there can be a real benefit. Improved health-related quality of life is certainly a component of this as well. Revisiting Kevin, this is our young patient with UC. He's on mesalamine. I have so many of these patients who come to see me in practice. They think they're doing okay, but they're really having increased frequency, increased bleeding. They clearly are having active symptoms, but they think this is just what life is. I have ulcerative colitis, this must be what it's like. So educating them, explaining that we really want to get them to a deeper remission. And in fact, when we tested his fecal calprotectin, it was sky high. He had a high Mayo score. And in fact, if you see the red box, it's around Mayo 2. That was his endoscopic activity, so moderate ongoing activity. So this is someone who clearly needs an escalation of therapy, that the mesalamine is not working for him. Importantly, guidelines, and for the most recent college guidelines for ulcerative colitis, do not recommend changing formulation of mesalamine in this scenario. You're going to get no bigger bang for your buck. This patient needs an advanced therapy. Okay, so just a discussion now. We've presented some great data setting the context from Jordan, and then obviously some data surrounding treat to target, earlier therapy, and how that could potentially improve outcomes. Jordan, I'd like to start with you. You mentioned you're going to wear 2 hats. I'm going to have you wear 2 hats. So this is a lot, treat to target. It means more scopes. It means more preps. Do you feel like, how are you as a patient potentially going to embrace this? Do you see the value? I mean, we should have a discussion about this to help people to see the value, correct?
Yeah, I mean, I think patients need to understand what exactly you said, what's the value in everything that's being asked of them. Yeah. Also, we have to remember that every time you order a test or a lab, it's another copay, right? And maybe more towards their deductible, what have you. So patients really need to be informed about why it is we're ordering, what blood work, stool studies, imaging, endoscopy. That's really helpful to set the stage, and it also allows you as a provider to understand, well, what is more important to the patient, right? And what are actually the patient's goals. But treat to target is in a model that can be very onerous to patients, and that needs to be really explained and needs to be backed up with the data that we've been talking about. And I think that can really inform patients and make them feel a bit more comfortable taking those steps with all those more potentially invasive assessments. Also speaks to the value of more novel assessments like intestinal ultrasound, things that are maybe less costly, that may be easier for patients to do to get those same data points.
Yeah, no, I've found that in my practice too, where if you can do a point of care ultrasound, they don't have to come back, they don't have to take more time off work. You know, there may not be a separate copay if it's part of the visit. It becomes a nice assessment to get real-time data then that patients appreciate.
Right, yeah, and I think that's been a huge help and comfort to patients. Also, they can in real time see what's going on. So if things are going well, great. If they're not going well, it's a good point where you can then intervene and say, well, here's what we need to do and here's why.
Right.
So Jordan, maybe I can ask you, where I see things going wrong in treat to target is particularly when the patient feels well, but we're not absolutely sure that objectively they are well. Convincing them that they need an objective evaluation can be quite difficult. So what can we do to help bring our patients around to that way of thinking?
Yeah, I mean, that's usually a point where a lot of the conversation needs to revolve around what may happen if we don't do something, right? So I think a lot of patients, particularly patients with Crohn's disease or small bowel Crohn's, may feel well until there is an obstruction, right? Until there is a complication that now it's relatively going to be much more challenging to manage with medical therapies alone. So I think setting that stage, not instilling fear, but just explaining what those risks are, for many young people, that's going to be a real challenge, right? Because if you're feeling better and you're 19 years old, you're just going to go back to college and drink a lot and not take your medications, because that's what college kids do. But I think having at least that insightful conversation about what the risks and benefits are of getting those data points and treating to a meaningful target that in the future will make them feel better, I think that's important.
But I think the other important point is, when you get them well, now that you're healed, that they understand that's not necessarily for all time. And if we want to keep you in that well lane, we have to keep checking something to make sure that you're doing well.
Yeah, I mean, it requires patients, particularly young patients, to really understand that this isn't just in this very moment. Like we live in a culture where everyone wants something right now, right? It's that impulse in the moment culture, and explaining someone that you're looking at, 50, 60 years into the future can be really challenging for young people to embody.
Yeah. And speaking of right now, it is time for us to move on
Yep.
to the next section. I feel like we could go on talking about this for quite a while. But now we're really switching gears. We're going to talk about an entirely new mechanism of action, TL1A inhibition, and how that might fit into the treatment paradigm. And we have to start by telling you what TL1A is. First of all, TL1A is TNF-like ligand 1A. So it is part of the tumor necrosis factor family or superfamily of molecules, but it isn't TNF. It's quite different. In fact, it's very upstream in the inflammatory cascade as compared to TNF itself, which is much more central to the cascade. And it does two things. Not only does TL1A have an effect on inflammation, and it has an effect on many different cell types, including innate lymphoid cells, Th17 cells, Th1 cells, and so on, all these bad actors that we see playing a role in both Crohn's disease and ulcerative colitis with all the downstream bad cytokines that occur. So this is very upstream. And so TL1A has broad pro-inflammatory effects. It's an early response cytokine that sets the stage for inflammation, so you can imagine that disrupting it could be beneficial. And it stimulates both innate and adaptive immune responses. The second thing that it does that is really quite different from TNF is it seems to inhibit fibrosis. So TL1A works through DR3 receptor, death receptor 3, and it has an effect, among other cells, on fibroblasts, which then elaborate not just things like TGF-beta and interleukin-6, but also fibrosis itself. And in animal models, blocking this pathway, usually with antibodies against TL1A, not only affects the inflammation, but also prevents or diminishes the fibrotic effect. And of course, fibrosis is important in Crohn's disease and the development of strictures, but it's also important in ulcerative colitis patients who, with chronic inflammation, they develop fibrosis of the wall of the intestine, leading to loss of function. So we have more and more data about this class of medications, and I want to bring you through a lot of these data, starting with the ARTEMIS-UC study. This was a phase 2 study of the first drug called tulisokibart, and comparing it in a blinded fashion against placebo in patients with moderately to severely active ulcerative colitis, defined in all the standard ways that we do in most trials. This was also a highly refractory group of patients. Patients had often failed, at least half the patients had failed one or more advanced therapies, most often TNF-alpha, but some of them, TNF-alpha inhibitors, but also some of them had failed JAK inhibitors as well. So a pretty sick group of patients. This was a simple study in the sense that patients were randomized 1-to-1 to placebo or drug. You can see the induction dosing was given intravenously 4 times over a 12-week period, and then you had the primary induction endpoint. Now, the other interesting feature of this, we were talking about predictive biomarkers, is this study tried to incorporate a predictive biomarker, which was a genetic-based test which was intended to evaluate the likelihood that a patient was genetically predisposed to elaborate high levels of TL1A, and therefore might be a better responder to blockade of TL1A. So we'll see how that worked out. And then responders were re-randomized to one of 2 maintenance regimens, either 250 IV every 4 weeks or a lower dose 100 milligrams IV every 4 weeks. So there were a whole bunch of usual different secondary endpoints, so let's take a look at all these data. Well, first you look at the clinical remission rate, and that was the primary endpoint at week 12. And first of all, what you see is the placebo rate was only 1%. That means this was a highly refractory group of patients enrolled in this study. And the effect size is 25% over that 1%. So that's a very remarkably effective agent at that time point. Then the responders, clinical responders, were re-randomized, and then at the end of week 50, it looks like the higher dose of 250 IV was a bit more effective than the lower dose of 100 milligrams. And you see that as well for endoscopic improvement, the same trends, as well as clinical response. Now, also you can look at symptomatic remission rates, and once again, you see this theme that the higher dose has a slight edge, although this was not powered for a comparison between these two different dosing regimens and maintenance, it looks like higher dosing was better. But across a range of outcomes that Millie told you are very important, not just the symptoms, but also histology in ulcerative colitis, and even in the same patient, histologic improvement and mucosal improvement, meaning endoscopy, both of them in the same patient, and mucosal healing. So in every respect, this drug seems to be effective. Now, you could also consider how did this drug perform in the advanced therapy naive patients as compared to those who had experienced an advanced therapy. If you look on the left, you're seeing clinical remission, and although there is a slightly higher absolute rate of efficacy in the naive patients, the effect size is not much diminished in the experienced patients. Also, look at that placebo rate in the experienced patients. It is 0. You can't go lower than that unless we're talking about negative numbers. Endoscopic improvement, it's the same story, although there you see that the naives did especially well, but still a very large, very important effect size of 25% in the experienced patients. Now, what about that test, that diagnostic test that was intended to indicate a positive test with a higher likelihood of response to TL1A blockade? Well, you can see that across a range of outcomes, actually tulisokibart was very effective for everything from clinical remission on down. However, although in the first cohort of patients studied, it looked like that test was a good predictive biomarker, when you added more patients in the second cohort, it did not look as highly predictive. So this is not necessarily the end of a predictive biomarker for TL1A. It probably means there's more fine-tuning to be done. What about safety? Well, here we don't see very much, and most importantly, we don't see very much in terms of infection risk. And of course, this is the induction data, so it's not years of data and it's small numbers of patients, but this looks to be quite safe overall. Now, there was a second study called APOLLO-CD. This was a one-arm study, so there was no placebo comparison. This was done with Bayesian analysis comparing to historical priors for what you expect with placebo in Crohn's disease patients of this sort. Again, you see the dosing regimen, primary endpoint at week 12, and a whole variety of primary and secondary endpoints. And this was a conventional moderately to severely active Crohn's disease patient population. So how did they do? Well, at week 12, 26% achieved endoscopic response, and you can see that this carried out through week 50 in these patients, and clinical remission also seemed to be maintained, in fact, even seemed to increase a little bit as time went on. So it does look like tulisokibart is also effective in Crohn's disease patients as well as UC. And that makes sense because another piece of evidence is that TL1A is implicated in genome-wide associated studies in Crohn's disease. So it is very important to Crohn's disease as it is to UC. Here are some of the secondary outcomes. You see clinical response, endoscopic and clinical response, or clinical remission. Biomarker and clinical response or clinical remission, and very importantly, corticosteroid-free clinical remission at the end of the year. Now, if I were to stack this up against, say, TNF, and remember these are older studies, when we look at TNF inhibitor studies, this is before all the other things, and this is a highly refractory group of patients, we're seeing outcomes that are quite similar to what we see with TNF, except in a more refractory patient population. Now, how quickly does it work? If you look at time courses for stool frequency, abdominal pain, general well-being scores, over days you see a drop in all of these things, and certainly by week 2 you see an important decrease in the symptom scores. And also correlating with that, you see reductions in fecal calprotectin and C-reactive protein by week 6 and 1 respectively, and sustained throughout the 12 weeks. So again, we're seeing this matched to what we're seeing in UC. Just as I showed you in UC, the safety data also looks quite good here. There's nothing terribly important that comes out of this, but we'll need much longer term data in larger populations. So the second agent to come along is afimkibart, and this was looked at in Tuscany 1, which was another Bayesian one-arm study, and here in Tuscany 2, a more conventional study with placebo comparison. Here, these were moderately to severely active UC patients. There was a screening period of 6 weeks. Patients were randomized to either placebo, a lower dose of 50 milligrams sub-Q every 4 weeks, a middle dose of 150 milligrams sub-Q every 4 weeks, or a higher dose of 450 every 4 weeks, with an endpoint at week 14 instead of week 12. Then there was also a maintenance period where placebo patients could be randomized to any of those 3 different doses. If you were on 50, you were carried on in 50. If you were on 150, you could be on the lower dose or 150. And if you were on 450, you could go to either of the 2 lower doses or continue on the dose that you were on. So it's kind of a complicated study in a way. I'll try to walk you through some of these results. So the primary endpoint here, again, was clinical remission at week 14. And notice that the placebo clinical remission rate is a bit higher here at 11.6%, even though these were very refractory patients overall. And it also looks like there's not a lot of dose response among the 3 different doses here, at least at week 14 for clinical remission by total Mayo score. Really, these are not distinguishably different. There's an important effect size with a delta of 12, so very good. And if you look at the modified Mayo score, actually the rates are a little bit better, and that was the scoring system that was used with tulisokibart that I showed you just before, slightly higher effect size. So turning now to clinical remission at week 14 and at week 56, you see these paired along the different doses, clinical remission by either scoring system. And you can see that it really looks like there's good maintenance over more than a year of treatment with this agent. We don't see dropping off. So unfortunately with TNF, that's one of the Achilles heels of TNF inhibition. We see at least 7 to 15% of patients drop off and lose their remission over the course of a year. What about rates of endoscopic improvement at week 14 and week 56? Once again, we don't see tremendously large differences between the different doses. All of them seem to look good. And once again, you see good maintenance of endoscopic improvement at week 14 and at week 56. Both of these outcomes are being achieved. What about rapidity of onset of effect? Well, certainly by 2 weeks, you're starting to see separation. I suspect if we looked earlier, we'd see even earlier separation, but definitely for rectal bleeding and stool frequency, there are greater rates of symptomatic remission in patients who are getting the drug, afimkibart rather than placebo, as early as week 2 and sustained through week 14 during induction. The safety data here also looks good, just as we saw with tulisokibart. There are no important adverse events that come through in terms of serious adverse events or serious infections. There was nothing that really emerged as important. The third agent is duvakitug. And if you're wondering why we're not seeing imabs anymore or zumabs anymore, we're just running out of names. So, now we have these other things at the end, and they are a tongue twister. But duvakitug, which I've learned to say, this was looked at in RELIEVE-UCCD. This is an interesting study design. It's a rare example of a basket trial where you're looking at both Crohn's and UC with the same agent in the same trial. So it's efficient in terms of recruitment. Of course, we have different outcome measures in the 2 different diseases, but at least the same site could be recruiting both Crohn's and UC in theory. So here there was a loading dose given subcutaneously and then a high dose, low dose, and placebo, followed out to week 12, I think it was, and then a longer term extension study. Once again, these were patients with moderate to severe UC or Crohn's disease. And in Crohn's disease, really, the primary endpoint was endoscopic response according to the simple endoscopic score for Crohn's disease, which is usually defined as a 50% reduction from baseline. So here you see the outcomes on the left-hand side for the UC cohort. You see an even higher placebo clinical remission rate here, 20%. That's really higher than we would expect. But still, you're seeing very large effect size of 27% over placebo with the highest dose of duvakitug, 900 milligrams, a little bit lower for duvakitug, 450 milligrams. And on the right-hand side, for the Crohn's cohort, where we're looking at endoscopic response, once again, it looks like the 900 milligram dose performs better, and that is a very large effect size. So it works in Crohn's, it works in UC. And if we look at efficacy according to prior exposure to advanced therapy, I showed you that for the other drugs as well, you can see that once again, the effect size is maintained, although the absolute rates are higher for clinical remission. For the naive patients, the effect size over placebo is well maintained in comparison to the naive and the experienced. And on the right-hand side, you see endoscopic response in Crohn's disease, and there it actually looks the highest dose performs equally well in terms of endoscopic response in both the experienced and the naive, which suggests that really there's no loss of response when you give that higher dose, even if you failed lots of other things. Once again, the safety data are very reassuring here. We don't see many serious adverse events or adverse events leading to discontinuation during induction. Now, these data for these 3 trials have launched 1,000 ships, so to say. Many, many different studies are ongoing now. I won't go through them all. There are other agents that are being looked at here. If you look in the middle there, there's SKYLINE-UC, which is a SPIRE agent, where actually it's an umbrella study, a platform study, where they have a number of different agents, including anti-TL1A. So you're going to see a lot of recruitment into these studies, a lot of activity, and it's a very exciting time with a very interesting new mechanism of action. And I'm going to turn it back to Millie for the last couple of parts.
Well, Bruce did a masterful job of getting through that data in a short time span. And obviously, thank you to everyone who's submitting questions. Please continue to do so. We will have a Q&A at the conclusion of the presentation as well, and there's some great ones already submitted. So I'd like to move into kind of a panel discussion here, where we just introduced a brand new class that may join our already enlarging arsenal of therapies for both Crohn's disease and ulcerative colitis. And Bruce, I know you've obviously been involved in these trials. You're very familiar with these agents. Who do you think are the patients most likely to benefit?
Yeah, I think all the studies included patients who were either naive to therapies, meaning they had failed conventional therapies. By that we mean things like steroids, 5-aminosalicylates, that sort of thing. But we also had a lot of multi-refractory patients, patients who had failed not 1, but 2 or 3 drugs or mechanisms of action. And so that would seem to suggest that you could use this for patients earlier in their paradigm or later in the course of their disease. Ideally, as you said, as you pointed out, we want to use very effective things very early. So I would say I would love to see this used early, and especially if we think that it might inhibit fibrosis formation, which really causes so many of the problems, especially in Crohn's disease, but also in UC. I would say we'd want to move these as early as possible, but could be using them anywhere.
No, and I think that one thing that's key is, I mean, granted, we have only early phase data and not necessarily the longer term, but the safety data look great, which
That's
really
right.
makes it for an agent that could be flexibly used early, late, in any position.
Yeah, it's kind of a shame that it has that TNF kind of superfamily link, but it's, it's a good family member, and it really seems to be quite different.
Actually, I have a question for you, Bruce. So you talked a lot about the biomarker and also fibrosis. Do we think that this class, which I think we all agree clearly works, right? I think that's always important early on in trials, is you want to make sure at least the pathway works. I think we can confidently say that now. But do you think we're moving forward with this potentially a biomarker approach with this class? And we talked about fibrosis, and what will we need to understand whether or not this really works for that?
Yeah. Gosh, wouldn't we all love not one but multiple biomarkers for each of the agents that we have? That's what we really need. but it's just so hard to do. And I give the sponsors of these trials a lot of credit for even trying to do it. There's a good rationale for it and a good scientific underpinning for it. I think that story is not over. I think biomarkers need to be tuned to what you're trying to predict, and I think we're going to see more work done on this. And the second part of your question was fibrosis. Yeah, how are we going to know if it works? It's hard. We have developed, we've proposed endpoints for clinical trials in patients who have stricturing disease. So that is a manifestation of fibrosis. But we have yet to see a study successfully completed entirely looking at stricture outcomes. So we'll have to see. My personal feeling is eventually we'll learn that this prevents laying down of fibrosis, not melting away strictures. It might do that if we're lucky, but I'd be happy if it just prevents fibrosis formation. That's going to take more time.
No, I agree. I think that it'll be hard, but the data will hopefully be forthcoming. And it speaks to that profile study that we discussed, the idea that earlier intervention, we may not have those strictures if we do things right. So I wanted to spend just a couple of minutes revisiting our patients before we move on to our Q&A panel. So I just want to orient everyone to remember Elise, who had that long-standing Crohn's disease with TNF failure, actually 2 TNF failures, and Kevin, our newly diagnosed UC patient who is biologic naive. So these are definitely 2 different scenarios. Jordan, in your mind, would either, both, who could be a good candidate for this class of medicine?
Yeah, I mean, of course, it's always hard to look into the future. But as Bruce showed us, speaking about Elise, there's data that this works in both naive and experienced patients, which is really important because not many of our existing drugs have that. So that's clearly a benefit so Elise potentially could garner benefit as a second or now third line, or at least a second class of exposure. And then Bruce also showed that the drug works particularly well, as most of our agents do, in that biologic advanced therapy naive patient. So both could clearly be good patients to potentially receive a TL1A inhibitor.
And I was impressed that while for some of the agents there was a drop-off, Bruce, but this seems to work well in the TNF exposed or the advanced therapy exposed patients. We still saw very good deltas.
That's right. Yeah, you saw deltas that were in a way similar to what we see with upadacitinib, almost as good, but this is not a small molecule. So, it won't have, for example, we believe that, we'll have to see with this agent, but we believe our biologics are going to be safe in pregnancy. This may be the same, it remains to be seen, whereas we don't really want to use upadacitinib or really most of our small molecules in pregnancy. So it's another scenario where it could be useful.
Yeah, absolutely. So, just a couple of final questions. I think that we talked a little bit about the fact that many could potentially benefit. At this point, no one in the room really has access, and so we're left in the realm of clinical trials. And, I think all 3 of us are involved in clinical trials, but how do you broach determining if a patient might be a good candidate? For someone who lives in an area where there is an academic center or other doing trials, how would they decide my patient might fit well here and start that process? Bruce, do you want to comment on that first?
Yeah, I would like to think that almost any patient who walks through the door could be a reasonable candidate for most clinical trials, but it's a little bit different to sort of persuade them to do it or show them the reasons they should do it is maybe the better way to put it. And I think one of the reasons is it's not just to contribute to science, it's because it can benefit them. This may have benefits that may go beyond the existing therapies. We can't promise that, but it's possible. But I think most importantly, we have limited therapies, and we've all seen patients who burn through one therapy after the other, some quicker than others. And once you go through all those failures, getting into a clinical trial is actually quite hard. So one of the persuasive things is maybe you should try this now, see how it works, and if it does work, most of these trials allow you to be on the medication for, in most cases, long periods of time, years, or sometimes till the drug is approved. It varies by the program. Why don't you try this now, see if it works, because you have a whole lifetime ahead of you with your Crohn's or your UC.
No, and I've been really surprised where if we don't offer it or potentially kind of say, this could be an option, the patient may not bring it up, but many of my patients are actually really engaged and they say, actually, I would really like that because they're motivated to help others and they're motivated, potentially to make a real difference in the field. Jordan, from the patient perspective, kind of having these conversations, is it ever wrong to bring it up? Or, what are the motivating factors that someone might be interested?
Yeah, I mean, we could have a whole hour panel on trials, right? Because there are so many factors that contribute to that discussion and that decision making. So I agree with Bruce and I agree with you that certainly any patient in theory could be a potential candidate for a trial. I think most of our sponsors and we appreciate that trials are inordinately burdensome on patients, right? So there is a huge amount of work. I mean, think about people who were physicians or lawyers or work in finance, or even if you work at Starbucks, how do you do a trial where you have to be in the office so many times and so many blood draws and so many stool tests and multiple endoscopies? It's really burdensome. So I think there's a little bit of a balance, and I agree with you. I think patients do want to engage with research. It's why everyone in our centers is in a multitude of studies, registries, and biobanking and so forth. But trials are very unique. And so in discussing trials with specific patients, there has to be a benefit that the patient is getting out of it. I think contributing to the intellectual understanding of whether or not a new mechanism is important, that has value. But patients also want to have individual value if they're going to be in a trial. And that's a balancing act. And finding the right patient for the right trial is also a balancing act. And as Bruce described, many of our patients, we start thinking of trials at the end of the line, right? You've burned through everything. That's probably the wrong person to enroll in a trial, but the right person who may be new to this disease is going to have a lot of difficulties maybe understanding that they're perhaps the right person for a trial.
I think the other thing you can say to a patient is you're never going to get more attentive care than when you're in a clinical trial. We are going to pay such close attention to you. Not that we don't already, of course.
Right.
Yeah, no, absolutely. And so I would just encourage you, if you're in an area where there is an academic center doing trials, reach out. And if patients are interested, please do refer. It's a great opportunity for patients. And so we have now entered the Q&A. I'm going to turn it over to Bruce to help to moderate some of the questions, both from the online audience and also from here.
Yeah, we have lots of great questions here, but only a few minutes to answer them. I guess this is one important question with already so many interested in this mechanism, and you saw there are at least 3 agents well along. What's going to be the differentiation factor among these 3 different TL1As, and I can tell you there are at least 3 others that are quickly behind them. What sort of things differentiate them?
I think modality of delivery, if it's all sub-Q versus IV, frequency of dosing potentially, there may be some variability there. In reality though, if someone has a biomarker that really differentiates, I think that will be the game changer. Because if I can know that my patient, if I measure this genetic assay, or we don't know exactly what's in a lot of these biomarkers, this black box, that they will have—
They're proprietary
biomarker, that they will have a 90% chance of responding to this therapy, or whatever that number may be. That would dramatically change practice, and I would use that drug definitively.
Yeah, I agree with that 100%.
Yeah, I think there may be one other thing which we didn't really talk about here, which is if you measure anti-drug antibodies to each of these, there are different levels of anti-drug antibodies. Of course, all the assays are different, and they're much more sensitive now than in the early days of anti-TNF. So I think we need to at least pay attention to that part of the story as well.
Mm-hmm. It speaks to potentially the durability of response, which
looked good for the durability that we saw, but we'll have to see. And another question here is, how do these drugs compare to IL-23 biologics and small molecules in terms of clinical and endoscopic remission? I guess I can answer that very broadly. They look as good or better. I think these are like infliximab-like results, presumably without the side effect profile of infliximab. They're approaching upadacitinib-like results. So the properties are different. and it seems to be safe, seems to be highly effective. Of course, we need so much more data to really know.
Well, I think of what you showed in that experienced population, the IL-23s are not as robust. So this is maybe where this differentiates.
Exactly. I mean, and the
Yes.
endoscopic response rates are what's so impressive in those biologic exposed patients. And, small bowel inflammation is very hard to heal. And so if we're actually getting that, that's also a game changer.
Someone is asking, can this work in a chronic fibrotic stricture?
We don't know, but I think
don't know.
not. And it's so hard in trials. Even how would you measure that outcome? Like, how would you, objectively determine lessening of that stricture? Certainly, I guess you could say, does the scope fit? Does it not? And things like that. But it's going to be hard to get at that outcome. I think, Bruce, you're right that these drugs are going to be great at preventing laying down fibrosis.
Yeah, the FDA requires not just symptomatic relief, but also objective evidence of improvement. So that means we're going to need to see symptoms of obstruction decrease, as well as probably radiographically, probably not endoscopically, some evidence of improvement of the stricture. And so that's kind of a little bit difficult, but I think someone is going to cross that bridge someday, and then we'll learn if this actually can reduce fibrotic strictures. I really want to thank both Jordan and Millie for great discussion, great presentations, and all of you for participating and showing up tonight.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by educational grants from Genentech, a member of the Roche Group, and Merck & Company Incorporated, Rahway, New Jersey, USA. To access all materials for this activity, visit peerview.com/WDQ860.